Good morning, and hello for everyone who's joining us on this webinar. My name is Bijan Manavazada, and I work for the Global Handwashing Partnership. I would like to say thank you for joining us. Our webinar, Wash Counts in Healthcare Facilities, commemorating Hand Hygiene Day, which takes place annually on May 5th. Before we begin, I'd like to tell you a little about the Global Handwashing Partnership. We are a coalition of international stakeholders who work explicitly to promote hand washing with soap and recognize hygiene as a pillar of international development and public health. The Global Hand Washing Partnership is comprised of the following steering committee members: Colgate-Palmolive, Unilever, FHI 360, USAID, the London School of Hygiene and Tropical Medicine, the Water and Sanitation Program at the World Bank, Procter & Gamble, the Water Supply and Sanitation Collaborative Council, and UNICEF. You can find more information about our organization at globalhandwashing.org, where you can read more about the work we do, our members, and about joining us. Before I pass the mic to our webinar's facilitator and co-host, Megan Wilson of Medentech, I would like to briefly address the partnership's work on WASH in healthcare facilities. The Global Hand Washing Partnership firmly supports the notion that healthcare-associated infections, like many other infections, can be prevented through the simple and effective habit of hand washing with soap. Over the past year, we have been more actively exploring and highlighting the importance of water, sanitation, and hygiene in healthcare facilities. In particular, improved hygiene to prevent infection spread in various health settings. Presently, we are working on a review of the latest evidence around hygiene in healthcare facilities and are developing a fact sheet on the role of WASH in preventing healthcare-associated infections. As we publish these resources over the next couple of weeks, they'll be shared on our website, globalhandwashing.org. We will also share a recording and a summary of this webinar in the next couple of days. Also, at the top of this slide, you will see several hashtags. We have been using these three to promote this webinar, and we'll be using them as we live tweet today. We encourage you to use them as well. I will now pass the mic to my good friend and colleague, Megan.
Thanks, Bijan. It's a pleasure to be with you all today. I work with Medentech, and I'm there in charge of partnerships. You probably know Medentech for our work in the WASH space. For the last 30 years, Medentech has been working to help people achieve their water treatment goals in the developing world, be that responding in emergencies, helping social entrepreneurs thrive, or distributing water treatment commercially. You may not be aware of the work with WASH in health facilities, especially disinfection. To give you an example, most recently during the Ebola epidemic in West Africa, Medentech was one of the largest suppliers of disinfectant, which helped government and health facilities combat this deadly disease. Today, this is what we're here to talk about today. In fact, how WASH in healthcare facilities can save lives. For example, at any given time, 10 out of every 100 hospitalized patients in developing countries acquire at least one hospital or healthcare associated infection. We all need to work to combat this. But how? As you know, the lack of improved water sources and availability of soap at many healthcare facilities in limited resource settings really blocks people from being able to make sure that they have safe and quality services. For healthcare providers, patients, and visitors to be able to practice good hand hygiene in healthcare settings, water and soap must be accessible. Yet, far too often, this isn't the case. According to a 2015 WHO UNICEF report that studied the availability of WASH in over 60,000 healthcare facilities, 38% did not have access to improved water source, over 19% did not have improved sanitation facilities, and 35% did not have soap and water for hand washing. And to add to that, practitioners and patients do not always comply with hand washing recommendations, even when soap and water are accessible. So all of this to say there's much work to be done, and together we can more effectively work to overcome these challenges. Our speakers today will speak to many of these points and more and talk about how we can work to address them. In particular, the objectives of our webinar are to, one, highlight the importance of water and sanitation in healthcare facilities to prevent the spread of healthcare-associated infections. Two, catalyze behavior change around proper hygiene in healthcare facilities and offer clear in-country examples. And three, highlight existing recommendations and tools intended to help each one of our organizations and governments improve conditions, services, and care in the healthcare setting. Today, we're thrilled and honored to have speakers from the World Health Organization, USAID's Maternal and Child Survival Program, the network member of PSI in Benin, ABMS, and Medentech. So I would like to first introduce our first speaker. Our first speaker is Arabella Hanter from the World Health Organization, who will share an update from WHO, the WHO and UNICEF's Global Action Plan on WASH in healthcare facilities. After her, Ian Moyes will speak from USAID's Maternal and Child Survival Program. And then following Ian, we will have Dr. Mbola, the Deputy Director of PSI Network member in Benin, speak, who will provide an overview of how ABMS works to support private sector healthcare facilities in Benin to improve hygiene and make services safer for patients. Lastly, Michael Gately, Medentech's Managing Director, will share some lessons learned from Medentech's work in infection prevention across the world and offer some tools for continued hygiene improvement. At the end, we will open up the floor for presenters to ask some questions. We would like to use this time to focus on where we go from here, not only looking at what we have learned, but how we can catalyze action forward. During the webinar, participants' microphones will be muted, but please ask some questions in the chat box. But after the presentations, we'll open up the microphone so that we can have a conversation and really figure out how we can move forward on these things. So as I mentioned, our first speaker will be Arabella Hanter. Arabella works with the WASH and Health Unit, where she supports the Global Action Plan on WASH in healthcare facilities. One of the main areas she works on is country capacity building, in particular, supporting the implementation of the Water and Sanitation for Health Facility Improvement tool. Having conducted WASH-Fit trainings in over 110 countries. She holds a master's from the London School of Hygiene and Tropical Medicine in Public Health and Nutrition, but worked in the WASH sector for the past several years. Arabella, it's my pleasure to hand the mic over to you. Thanks for joining us.
Thank you very much for that introduction, and thank you also for inviting me here today to be part of this webinar. It's great to see so many people on the line, some of whose names I recognize from having contributed already to work on the Global Action Plan on WASH in healthcare facilities. So thank you to all of you for your participation and contributions in this field of work so far. I'm going to give a very quick overview of the Global Action Plan on WASH in healthcare facilities, which is being led by WHO and UNICEF. And this is really just a very quick snapshot of work. There's so many fantastic bits of work going on in all corners of the world. So do bear in mind that this is only going to be a very small amount of the work that's currently happening. And I'll share at the end of the presentation some links where you can find out more information and sign up to the newsletter on WASH in healthcare facilities. So firstly, just to present here some of the global data on WASH in healthcare facilities, which Megan already highlighted in her introduction. And this is from a 2015 WHO and UNICEF landscaping report with data from 54 low and middle income countries, which highlighted the very poor access to water and sanitation and healthcare waste management across the world. And as you see the shocking statistics of access to water, which is that nearly 40% of facilities in low and middle income countries don't have access to an improved water source. And that figure doesn't include quality or reliability. So when that is taken into account, water coverage drops by almost half. Also, the very poor coverage of hand washing facilities and sanitation, with 35% of facilities lacking soap for hand washing and 19% without sanitation. Also, not to forget healthcare waste management, which is included under the Global Action Plan on Washing Healthcare Facilities. And that report highlighted that more than 40% of facilities don't have safe practices for healthcare waste, which has huge implications for human health. So what are we doing about this situation? Well, in 2015, WHO and UNICEF launched a global action plan at a global meeting held in Geneva. And the vision of that action plan is that by 2030, every healthcare facility in every setting should have safely managed and reliable wash facilities and practices to meet staff and patient needs in order to provide quality, safe, people-centered care. And this idea of quality is really at the heart of what we're trying to get at. So the idea that you cannot provide quality healthcare services unless you have adequate wash in place to reduce infection, to increase staff and patient morale, to increase patient satisfaction, and a number of other benefits, which I believe other presenters will highlight in subsequent presentations. And working to meet that goal are partners and organizations in countries all over the world, and they're structured into 4 task teams, which you see there. So for this presentation, and given the limited time, I'm just going to focus on a couple of examples of work that the advocacy team and the policy standards and facility improvements team have been involved in. But very briefly, the other 2 teams on monitoring and evidence and operational research. The monitoring team is tasked with defining indicators for monitoring wash in healthcare facilities globally for the Sustainable Development Goals. And it's the WHO-UNICEF Joint Monitoring Programme who are responsible for that piece of work. And a set of core indicators on wash in healthcare facilities has been developed and is available on the JMP website. And work is underway to get those integrated into existing national and global surveys and also into national health monitoring information systems. The other team on evidence and operational research, led by the London School of Hygiene and Tropical Medicine, is currently working on a systematic literature review to look at the effects poor wash services have on healthcare-associated infections. And the search terms and outcomes have been identified, initial searches have been run, and results will be available towards the end of 2017. Of those 4 task teams, they all have a set of change objectives and related targets, which you see there. And we don't have time to go into great detail on all of those, but I'll just focus on the first change objective and the last change objective from teams 1 and teams 4. The Sustainable Development Goals, which run from 2015 through to 2030, also provide a great opportunity for catalyzing action around wash and healthcare facilities. And of the 17 goals, there are 5 which relate directly to wash and healthcare facilities. So number 6 is the most obvious one of those, on universal access to clean water and sanitation. And although there's no specific goal on access to wash in healthcare facilities, wash in healthcare facilities is included under universal access to wash in institutions. So that includes schools and healthcare facilities. Also, strong links with goal 3 on good health, particularly around maternal, newborn, adolescent and child health. And for Goal 7 and Goal 13 around renewable energy and climate action, so work towards greening the health sector, reducing harmful emissions from incineration of healthcare waste and a range of other activities. And then finally, number 17 on partnership for the goals. And WASH in healthcare facilities is a great example of where partnership and collaboration is incredibly important. This is no longer to be seen as just an issue for the WASH sector, but something that the health sector should take on and take up. So a few examples of work under the advocacy group. So the main target of the advocacy team is that WASH in healthcare facilities should be prioritized as a necessary input to achieving all global and national health goals, but particularly those linked to universal health coverage, maternal child health, antimicrobial resistance, and infection prevention control, which of course has strong links for the upcoming 5th of May Global Hand Hygiene Day. And the goal of that is that WASH in healthcare facilities standards and measures should be embedded into health strategies and frameworks. So a couple of examples to present on infection prevention and control. WASH has recently been included in the new WHO IPC core components and the surgical site infection guidelines, which were both launched at the end of 2016. Also here you see a flashing image of the tagline of this year's Global Hand Hygiene Day, which the focus of which is fighting antibiotic resistance, it's in your hands. And there's a number of materials and advocacy tools and documents that you can use to help raise awareness on this 5th of May. Next, on antimicrobial resistance, so WASH is highlighted as one of the 5 key objectives in the WHO Global Action Plan. So that's great to raise awareness in this ever increasingly an important area of work. Next, on maternal, newborn and child health, WASH has been included as a core element in the new quality of care framework, which was launched in 2016 by WHO. And this is a really fantastic opportunity to see WASH embedded within the health sector and to get the health sector taking the issue of WASH in healthcare facilities on board. So that was just a very quick overview of some of the advocacy work. And as I already mentioned, there's more information and more work being done than can possibly be presented here. So I'd invite you all to go to the WASH in Healthcare Facilities knowledge portal, which has lots of information on these pieces of work, and I'll share the link at the end of the presentation. So now I'd just like to move on to the main piece of work that that 4th task team on policy standards and facility improvements has been working on, which is the WHO and UNICEF Water and Sanitation for Health Facility Improvement Tool, or WASH Fit. This tool was recently launched at a global learning event on WASH in healthcare facilities in Nepal last month in March. But it was originally written and created in 2015. The methodology of the tool is based on WHO's water safety plan, and the aim of the tool is to help facilities to better manage their WASH services based on a risk assessment which enables them to prioritize areas for improvement to enable them to make improvements to the quality of the services that they provide. To date, the tool has been used in a number of countries, predominantly in Africa, and the idea of the tool is that it can be adapted to different contexts and to different needs. So you see there a few examples where the tool has been used and in different contexts. So in Liberia, as part of the Ebola recovery work in late 2015 and 2016, in Mali, as part of a 3-year project between CDC, WaterAid and WHO with more of a focus on maternal child health. In Chad, in very small facilities in resource poor areas looking at reducing cholera. in Madagascar with a focus on healthcare waste management, and most recently, last week, we conducted a training in Ethiopia to integrate Wash Fit with an existing national quality improvement strategy. Wash Fit is designed for use in primary and in some instances secondary healthcare facilities in low and middle income countries. Also, as part of this work, CDC are developing an evaluation framework, which we hope to have ready in the next couple of months. So please watch this space for that piece of work. Lastly, we're very excited to have been working with M-Water, an organization based in the States who provide technology, online technology for water-based projects. And they have helped to create the WashFit mobile app, which is an online version of the tool to enable better data collection and analysis at the district or national level. The tool was only launched last month and is therefore still just in a prototype. We would encourage you to visit www.washfit.org and set up a username and play around with the tool and explore what the tool can do and how it can be used. And we'd welcome any feedback that you have to try and make that tool better and develop it over the next few months. A few pictures here just to show you from our work in Chad. And WashFit is a tool in order to help facilities, as I said, in very resource poor areas where facilities have limited financial resources, but also technical and human resources to make big improvements. So WashFit focuses on helping facilities to make small incremental improvements. And here are just a few pictures from one facility which implemented WashFit in 2016. And they're just to give some idea of the possibilities that WashFit can help with. So for example, on the left, planting plants by the entrance to the facility to make the environment more attractive and to try and encourage people to use the facility. Also gender separation of latrines, so a simple low-cost intervention by painting male and female signs above the two doors. And then the last picture there is a hand hygiene promotion picture, which was drawn by one of the staff members at the facility. So again, a very low-cost improvement, but one which we hope can have a big impact. Finally, just a few areas to highlight that have been identified as priorities and next steps for the strategy of WASH in healthcare facilities. Now that we're 2 years in, it's time to take stock of what works and what doesn't work. And as we've already seen from the 2015 meeting landscape report, that information, I think, is well known now. And we're aware of the problem. There's more and more data coming from low and middle income countries, and now is the time to take action. So a few areas that have been identified as priorities include proof of concept and scale up, developing tools, training and ways of empowering facilities to make changes, innovative financing and sustainability, monitoring and accountability, and strengthening the evidence base. Finally, just a plug to encourage you all to visit the WASH in Healthcare Facilities knowledge portal at www.washinhcf.org. The website is available in English and in French and includes updates on activities happening across the world, country case studies, resources, publications, presentations. And if you have any information you would like to share on work that you're doing on WASH in healthcare facilities, please do get in touch and we'd be happy to upload it to the website. Finally, just some useful links there, a link to our website. Do please sign up to the newsletter, which we send out quarterly. And lastly, our Twitter handle at wash_for_health. We hope that you keep in touch and share the interesting and important work that you're all doing. And with that, I will pass back to Megan and the team for the rest of the presenters. Thank you very much.
Consulting firms, World Bank, and foreign governments. His current work focuses on the nexus of wash and nutrition, as well as what we're here to talk about today, wash in healthcare facilities. Ian received his master's in environmental science and policy in 2003 from the University of Oregon. Over to you, Ian.
Thanks very much, Megan. Thanks to Medentech and to PPPHW for hosting this event today. Very thankful to be able to share our experiences. And thanks for Arabella for setting the stage. It seems several of these events I'm always following Arabella. So you'll see some parallels. So it's actually nice that she does some of the work for me. I am the WASH advisor at Save the Children. We are the WASH lead on MCSP, the Maternal and Child Survival Program, which is USAID's flagship global award. It's $560 million. We're operating in about 25 countries. It really affords us as WASH advisors the opportunity to work hand in hand with health colleagues and address some of the challenges that there are when you're mixing health, the health system, and WASH and engineers and the way we look at problems. So that's a lens that we bring to this challenge, and it's one that I think is pretty useful. The clean clinic approach is our approach, and I'll get into that as we go through the presentation. One thing to note about it is that we're a big focus on management, so getting away from infrastructure and more on management with clean clinic. Next slide, please. Right, so just the agenda, WASH and healthcare facilities in the healthcare system. As I mentioned, I'll talk about that nexus of those two, of WASH and healthcare. Then I'll get into the clean clinic approach, and then I'll talk about Centre Santé Hope, which we affectionately call the clean clinic approach in Haiti. Next slide, please. Right, so WASH and healthcare facilities and the healthcare system. We've known about WASH, the necessity of WASH, good cleanliness in healthcare facilities for a long time, but I think one of the problems is we just haven't drilled down and known exactly what that means. We think it means incinerators, we thought it meant boreholes, a lot of kind of traditional classic WASH things, but we've never really been forced to kind of tackle those challenges, ask the questions, and investigate it. And more, we actually haven't focused on WASH for maternal and newborn needs specifically. So it's with the rise of the Ebola crisis recently that we were really forced to do that. There was a lot of money and investment put in the WASH and healthcare facility space, and that led to the rise in WASH and healthcare facility programming. And so it's really the Ebola crisis that forced us to address some of these things and ask some of these questions. I'm going to talk a little about some of these challenges between these two spaces, health and WASH, and then some of the frameworks and the evolving way that we look at these problems. Next slide, please. Right, so some of the challenges, from our perspective, there's a lack of accountability within the health system. So we know that WASH is covered by many ministries, whether it's rural development, whether it's health, whether it's water, environment, a number of different interests. Whenever there's WASH that comes up, we always kind of think it's someone else's problem. But the Ministry of Health, even though they have the responsibility to deliver health, they don't necessarily take on WASH as their responsibility. We have, as the link you see there, we've written a piece about this that you can read kind of some of the challenges outlined more thoroughly. But really, the challenge is how do you make the health system accountable for WASH in healthcare facilities? Secondly, the solutions, as I mentioned, have often been seen as infrastructure. So the problem is over there, it's that we don't have a good water point. It's that we don't have access. And we don't think of things like, we're starting to think of problems as hygiene related, but not as much as management related, whereas many of the problems indeed are management. The disempowerment of healthcare workers, and what I mean by this is that you have WASH standards that may be unattainable, and so that prevents some action by lower level healthcare workers. So even though you don't have a red bin in a facility, that doesn't mean that you can't do improvements to your waste management. As we all know, there are plenty of incinerators out there that are defunct and unuseful or unused, and yet right next to it is a pile of garbage. So what can we do to improve that system? This is one of the challenges. There's different personnel in this space. So you have medical doctors on one side that are a little bit more curative and work inside the hospital, and you have engineers on the other side that are tend to build things. That's the way they solve problems. And so there's these two kind of, and these are very general categories, but these two categories of people trying to address the same problem. And then IPC versus WASH and healthcare facilities. Again, working on a global health project, one of the challenges that we faced was defining what these two things meant and how they work with each other. What is IPC and what is WASH and healthcare facilities? Are they different? Are they the same? And I'll get into that on the next slide, please. So when we started looking at WASH and healthcare facilities and working with medical doctors and health professionals under MCSP, we identified some of these general differences. So IPC focuses more at the micro level, whereas WASH and healthcare facilities is more at the macro level, more of a systems approach. I like to say inside four walls is what IPC is doing, and outside four walls is what WASH and healthcare facilities is doing. The approach, as I mentioned, the difference between a clinical lens and an engineering lens. Both focus on infection reduction, both focus on behaviors with a special emphasis on hand washing. Where sanitation might be a little different, whereas under the IPC umbrella, you're looking more at surface areas, linens, and needles, whereas the WASH and healthcare facilities broader lens looks more at latrines, hygienic facilities, maintenance and cleaning. And the waste management may have a little different spin on it. So under IPC, disposal of needles, biomedical waste. Under WASH and healthcare facilities, a lot broader collection, treatment, collection, evacuation, and treatment of those same needles. Next slide, please. So just to give a flavor of one country's evolution of WASH and healthcare facilities, previously they had a WASH and healthcare facilities policy. Under that, they had two branches, infection prevention and control and the management of medical waste. They have since changed with the assistance of WHO, UNICEF, and local partners. The new structure that they've come up with on the national policy now has WASH and healthcare facilities as an umbrella. It covers infection prevention and control, potable water, human waste, gray water, biomedical waste, vector-borne and infectious disease management, and hygiene promotion. So you can see that WASH and healthcare facilities is becoming this umbrella category that you then cover a lot of the systems within the facility that address WASH. For MCSP and countries that we work in, we're using this model where WASH and healthcare facilities is the umbrella platform to implement, among other things. Next slide, please. So the Clean Clinic approach is currently being implemented in Haiti, Mali, DRC, and Mozambique. It's a management-based approach, and I'll get into the steps of it. Next slide, please. So several of the objectives for our Clean Clinic approach. One is better facility management, as I mentioned. A lot of times there are things, people think that you can't do anything because the incinerator is broken, as I mentioned, but you actually can do stuff, and it's a question of leadership and management. A second objective is empowering health facility staff, so giving people the tools to actually look at problems, analyze them, and solve them, plan for solving them, and solve them. The third one, naturally, infection prevention is critical. The next one is increased client satisfaction and attendance. And I don't know if anyone noticed the plants that Arabella had on her slide, but I joked about this the last time. Really creating an environment and space where people want to come to increase attendance at the facility. So client satisfaction and attendance, focus on low resource settings. So of course, when there's nothing, when there's very few resources, what can we do? And then integration into the health system and the other health system entities such as quality improvement and health system strengthening. Next slide, please. Just several elements that we like to think about in our Clean Clinic approach. One is doable actions. So as I mentioned, you'll see parallels between the WASH Fit tool set and the Clean Clinic approach. In fact, we use many of the same tools and elements, including focus on doable incremental actions. So even though you may have a standard in your national WASH and healthcare facility policy, it doesn't mean that you can't make incremental improvements that may be more feasible with a limited budget. Second is government ownership. So this is really a policy that government needs to own. You can imagine, as we all know, implementing at a pilot stage, 10, 20 facilities is quite easy, but if you want to reach national scale, if government hasn't adopted your approach and incorporated into their existing systems, you won't achieve that scale in a sustainable manner. The third element is integration of WASH action plans into existing systems. This is really important. It'll come back again at the successes level, and that is not trying to duplicate systems that already exist. Every healthcare facility has an action plan. They have an annual budgeting process, so it's really integrating WASH actions into that budget and process. competition and social recognition-based rewards. We know that rewards, monetary rewards, is not always a sustainable system, especially with limited national budgets. But we do know that recognition by your peers is always going to be there, and so we leverage that in the clean clinic approach. Lastly, leadership training. We've also seen when you train leaders both at the government level and the district facility, or the district health teams, as well as at the facility, when the leadership actually knows what has to be done, knows the path to get there, that the rest of the staff can follow that leadership. So that's another element for us. Next slide, please. So just quickly to run through this clean clinic approach process, healthcare facility assessment, establish and refine national and minimum wash standards with the government, develop the program parameters with the government, train district and healthcare facility leaders, introduce the clean clinic approach in target healthcare facilities. So that's kind of the introduction of the program. It happens at national and district or local level. Next, you've got integration of WASH action into annual work plans, monitoring progress and coaching, inspections and scoring. So we have an inspection checklist that allows us to score each facility, and then we share the results of those results with the participating facilities. Reward of healthcare facility progress. So social recognition rewards, whether it's a set or a party, or whether it's actually radio or TV announcements of the results, and then refine priorities, action plans, and continued improvements. Next slide, please. So just to go through a couple results from our work in Haiti under the Santé Pro. Next slide, please. We have 4 status levels. Apart from the end goal of clean clinic approach, we do have these intermediate steps that people can achieve. Next slide, please. It's guaranteed silver, gold, and diamond levels. You see here that out of the work that we've been doing, clean clinic approach, so over the first, from the baseline scores, average scores improved by 14 points. 2 facilities achieved silver status, while 5 achieved guarantee, so making incremental steps and improvements, but also having the impact to continue work. And 6 months, even after Hurricane Matthew, we didn't see any change in levels from the scores from facilities. 65 trainers were trained across 7 departments. This is a really critical piece of the pre-service training and getting people familiar with the approach and able to implement it. And then we're now scaling up to 69 health facilities after the 20 pilot facilities. Next slide, please. Just really quickly, we're running out of time here, so to go through the successors. Integration with a health project, as I mentioned, MCSP's global platform allows us to work with the Ministry of Health and inside the Ministry of Health. Government ownership at central and district levels, leadership training, social recognition has proven a really strong motivational tool. The inspections are really critical. Having government, district health officers conduct inspections, integration into existing processes rather than setting up duplicate ones, and then validation and empowerment of staff, especially cleaning staff. This is an underrepresented. We consider cleaning staff in our approach to be frontline health workers, and they are their validation, whether they're paid by a salary, whether you give them a uniform, whether you include them into your meetings and your planning, really critical for the success of the clean clinic approach. Next slide, please. So just an overview of the success. Really working at all levels is important. So we worked at national level on training modules, policy work, and coordination. We did develop some pre-service training modules in teaching hospitals and really feel that's a critical piece moving forward. And then in the field, the TOT, we provided a mini starter kit for each facility with some basic cleaning materials, training, and coaching. Next slide, please. So next step for us, evaluation of MCSP. We have an assessment we're about to conduct for the next couple months of the work. It's going to focus on both our IPC work, our postable IPC work, and the clean clinic approach work. Integration with JMP monitoring indicators, so the results from clean clinic work can actually be represented on a global, in the global monitoring. And then leveraging community for accountability. We know that the government will not always be motivated to do the inspection visits, but we're hoping to integrate community as part of that accountability mechanism for facilities. Next slide, please. I think that's it. Thanks again for the opportunity to share the Clean Clinic approach, the work we're doing. And over to you, Megan.
Thanks, Ian. That was a really great presentation. I loved, in particular, the in-country example. It just sounds like a fascinating example. Let's hope they all get up to that what is it, the platinum level?
I think the term is Clean Clinic.
Oh, Clean Clinic. Okay, so now we're moving on to, we move from Haiti, we're moving on to Benin. We'll hear from Dr. Mbola, who's the Deputy Director for Programs at ABMS. It's an affiliate member or network member of PSI in Benin. Dr. Mbola leads ABMS's family planning, HIV, maternal and child health programs, as well as WASH. She joined PSI in 2010, or pardon me, not 2010, 2002, and has held a variety of positions related to social franchising and health service delivery, and has been an active promoter of health quality assurance in healthcare facilities for over 10 years. In addition, Dr. Mbola was an active practicing physician in a private healthcare facility in Madagascar, where she provided care to over 500 patients a month. She received her medical degree from the University of Antananarivo in Madagascar. Dr. Mbola, vous êtes la bienvenue. Please start your presentation.
Thank you, Megan. Thank you, Megan. Good morning, everyone. And I'm very happy to provide an overview of our support to the private healthcare facilities in Benin to improve quality of care, including water, sanitation, and hygiene. Next slide, please. ABMS is a Beninese Association for Social Marketing, which is a network member of PSI in Benin. Part of ABMS' mission is to make quality health services available for the population. And to work toward this mission, we launched a network of private clinics called ProFam Network in 2004 with the USAID support. And as you know, the private clinics play a great role in the provision of health services. A recent study in Benin showed that about 60% of population seek care from the private sector. And currently, we continue to provide support to 180 private clinics in the country to improve access to quality family planning, reproductive health, and HIV services. Next slide. So we put in place a quality assurance and quality improvement system to ensure that patients receive quality and safer services, and that there are systematic and continuous actions that lead to improvement in healthcare services. We know that when we talk about improvement, it's occurring in incremental steps, and so we use these 5 wheels to improve the quality of services in the private clinics, which are the standards, protocols, and guidelines, which are in line with the national and international guidelines, the trainings, the supportive supervisions, quality assurance audit, and adverse event management. Next slide, please. So all the quality assurance activities are built around these 5 standards. The technical competency, so the providers should have the required license to provide the services, and also to have the right skills. There is also the informed choice, the privacy and confidentiality, and the continuity of care. During these presentations, I will focus more on client safety. Next slide, please. hand safety is part of the 5 standards and is, among the important standards. There are 3 standards that are highlighted in blue in your screen. The first one is the compliance with the minimum facility standard. So we should ensure that the health clinics have the required infrastructures, for example, clean water, running water, availability of latrines, toilets, and water point. The second indicator is the compliance with the procedure of infection prevention. So this begins with hand washing, disinfection, sterilization, safety disposal of used materials, and waste management. The third one is related to the availability of equipment and consumables like the gloves, bleach, and other products. Excuse me. Next slide, please. We also provide trainings to providers. Right after joining the network, each provider receives initial training on the health areas and also on infection prevention. So these trainings include practice and simulations, and it happens also that we organize exchange visits between providers and to exchange their good practices. Next slide, please. Next slide, please. Okay, thank you. The suppurative supervision visits are also an important part of the quality assurance. We need to ensure that they are frequent enough to be sufficient in assuring quality. In general, the frequency is quarterly, but it depends on the performance of the providers. So we really need to care to ensure that the supervision is more targeted for better allocation of resources. So, for example, for some providers who are a good or a high performer, the visit could be less frequent. But for those who need more support, we need to increase the frequency to monthly or to every 2 months. We use the provider's behavior change communication techniques to improve the behaviors of the providers. And also we encourage the peer support. So the providers who are high performer are invited to join the supervision team to provide support to their peers. After each supervisions, so there are follow-up actions on the action plans. Next slide, please. This slide shows the stairways for behavior change that we use to improve the behavior of the providers. We work with different types of providers. We work with medical doctors, with nurses, with midwives, and also with health assistants or health agents. So the objective of our activities to move the providers in the 2 stairways, adoption and advocacy. For example, for WASH component, we want the providers to behave in a systematic way. For example, to wash their hands in a systematic way, to wear gloves in a systematic way on the critical moments. And we want them also to be an advocate for their peers, so they can, the high performer providers can sensitize their peers during the exchange visit or exchange meetings. Next slide, please. The data are very important for decision making. As I said, we have norm standards for supervision that each provider receive quarterly supervision. But it is also important to see the performance and to allocate the resources to those where the needs are higher. And so we use the data from the supervision, but also the data from, for example, the client flow, to see where are the priorities. And so the analysis of data is very important. Next slide, please. As part of the quality assurance plan, BMS conducts audit, internal audit every year, and we also receive external audit from other people external to the platform every 2 years. So the objective of the audit are to ensure that the provider deliver high quality services and to ensure that there is a robust system to monitor and maintain the high quality services. And the audit involves not only the providers, but also the medical staff who provide the support to the providers. Do they have the required the competencies, and do they apply it correctly? And so these are all part of the audit findings. Next slide, please. Okay, so as you can see, these smiley faces are during an event where we recognize or we reward the best performer, the providers who are complying with the norms and standards, or those who made a big progress. And this is really important, that to encourage them to maintain their behaviors. The motivation system is also an opportunity for a BMS to give them, to provide them additional equipment to improve the quality of services in their health facilities. Next slide, please. So what we have learned, first of all, we know that the supply of equipment and commodities is very essential. It's very important, specifically in the beginning of the activities. So this is like samples when you would like someone to try some behavior. So we need to make their work easier, their test, their trial. So we provide them some commodities and also equipment in the beginning of the program. It is also important to maintain the level of quality with the consistent supervision. Repetition is very important, and the providers need close follow-up. There is also important to monitor data for decision making, the scoring from the supervision, the quality, but also the client flow. So try to match all the data that we have and for decision making. It's really important to implement motivation system for providers, not only to recognize those who are good, but also to encourage the others to do better. And the last point is related to the integration of water sanitation and hygiene into other health programs. As the case of ABMS, the focus is on family planning, reproductive health, and HIV, but WASH is the kind of cross-cutting activities that we promote along with other programs. Next slide, please. Okay, so the picture in your right, so this is a woman. She's not a patient, but she's a accompanying person. And during after the Ebola outbreak in the region and the case of Lassa fever in Benin, so this becomes a requirement that every person that goes to a facility wash their hands first. And so this is an opportunity for the health agent to teach all the visitors on how to do better hand washing. And the picture in your left is the waiting area in health facilities, where we put some posters on cleaning water and also on washing hands. So the healthcare facilities are really a key place for wash education, not only for staff, but also for patients and family members. And we know that this will improve their wash practices beyond the clinics at home, such as regular hand washing with soap at critical moments. And so the providers have dual role as supplier of health services, but they are also implementers of behavior change. Next slide, please. So this ends my presentation. So I would like to express my thanks to all our partners listed here: the Benin Ministry of Health and local officials, USAID, the Kingdom of the Netherlands, UNFPA, KFW, Women's Health Program, and PSI. Last slide, please. Thank you all for your attention. So I'm happy to answer your questions and provide further information. You may also want to visit the ABMS website and Facebook page for more information. Thank you.
Thank you, Mbola. That was a great presentation to show what good work is being done in WASH and healthcare facilities in Benin. I particularly like the smiling faces of the motivated healthcare providers that you showed. So we hope that we can make more healthcare providers motivated so they offer higher quality services. It is now my great honor to introduce Michael Gately, who is the Managing Director of Medentech. Michael has worked in more than 75 countries on infection control and prevention issues and has supported the emergency response and disaster relief efforts around the world. He visits around 25 countries each year to offer training on infection control and prevention, and works frequently with the infection control industry in the U.S. He has presented training programs to a variety of organizations, including PAHO, the Red Cross, and frequently collaborates with universities on infection control research. Michael holds a degree in social science from the University College Dublin and an MBA. He also has completed the Certified Mastery in Infection Control and Certified Healthcare Environment Service Technician Trainer training from the Association for the Healthcare Environment. Over to you, Michael.
Thank you very much. Is there an echo on the line, or is it okay to continue?
I'll keep going.
That's fine. Well, look, everybody, it's an honor to speak with you today, and hello to our friends from all over the world that I see have registered for this event. You can pop down to the next slide, please. I'm sure most of you, or all of you perhaps, know Aquatabs. For the past 35 years, we've served the world's lowest income countries, both with water treatment and with infection control products and programs. You can go to the next slide. Safe water itself is a critical element of the Sustainable Development Goals, and working through multiple programs and channels of distribution, we've supplied over 11 billion litres of safe water last year alone in small doses. So really supplied the safe water right at the point that it's needed, where big systems are simply not available. You can go to the next slide. So our infection control products, surface infection control products, are used in 4 out of 5 of the top US hospitals and in most British and Irish hospitals. And our customers, as I say, all over the world, they range in the low-income people right through to some of the best hospitals in the USA. Next slide, please. Now, this next message I give to you is very important comment. Disinfection is the first line of defense and the last line of defense. Now, what I mean by that is that proper disinfection prevents diseases beginning in the healthcare sector and is the last line of defense against antibiotic-resistant mutant germs. So wash, water and sanitation is very important. It provides a Rubik's Cube of benefits. Wash is important for the quality of care, it keeps saving lives. So for example, one germ alone in the United States, Clostridium difficile spores, is killing 14,000 patients each year who acquire the germ while in hospital. So one can only extrapolate and imagine, speculate what happens around the rest of the world. So proper infection control reduces the cost of the hospital of extra bed days and extra drug use. It reduces the productivity loss of the patients that we serve in developing countries. Many of these patients are only earning $1 to $2 a day, and those earnings are critical to their family. It also reduces the hospital staff productivity loss through their sickness. This is a real risk, and I want you to keep that in mind, because when we talk about in a moment about behavioural change, this is a critical point. Certainly amongst the families of healthcare workers, there is a higher disease rate than amongst the families of patients. And finally, proper infection control, proper wash, helps address antimicrobial resistance. So we're the first line of defense and the last line of defense. Next slide there, please. Now, Medentech has over the last 35 years, we've learned how to help you with both the product and the behavioral change elements of the programs. I myself, as I said, am a social science, and Medentech, we help you with the important behavioral change issue. In infection control, you have a difficult task to influence healthcare workers on the invisible threat, because it's a germ that they can't see. So it's a germ where they can't see, where the benefit of behavioral change in terms of proper infection control is enjoyed by somebody else. It's enjoyed by the patient. So a third party. For this reason, one must make the message personally relevant to healthcare workers to get them to behavioral change and do proper infection control. It must be simple and it must be repeated. And in this photograph, I show you a very simple example of some of the training that we give. People self-infect by putting their fingers in their mouth, their nose, and their eyes. This is what we refer to as the T-zone. So we train people very simply, don't touch the T-zone. And so we're making the message personally relevant to the healthcare worker, so they don't either self-infect or transfer from these eyes, nose, mouth, T-zone area to the surfaces in the hospital, thus infecting patients, and ping-ponging between both. So this is just a simple example of some of the training that we can help you with and provide. You can, next slide, please. Of course, a very important part of the training we do is to help identify for healthcare workers what germs are. From all our AquaTabs behavior change work, we've learned that people may not simply believe that germs exist or are in water if they cannot see them. So what we teach are what the germs are and where they are, and that frequently touched surfaces near patients are the most critical areas, especially for acute care patients. Not to forget, of course, mobile phones, because they're ubiquitous these days. Next slide there, please. So this next message I'll give you, apart from the behavioral change, this next message is really important. There are many, many disinfectants on the markets that really are not much better than water. So a disinfectant that claims that it kills 99% of bacteria is just inadequate for the clinics. So what you really need is a disinfectant must be effective in 4 minutes or less. That's before it dries. If the disinfectant doesn't kill the germs before it dies, then it's lost its efficacy. A disinfectant must achieve a 6-log reduction in germs, 99.9999%. If it doesn't do that, it leaves behind pathogenic germs at a concentration rate on the surface that will kill people. A disinfectant needs to kill a broad spectrum. It needs to kill bacteria, microbacteria, fungi, spores, viruses, and critically biofilm. So all those different families. A biofilm, by the way, 90% of hospital germs, even on dry surfaces, live in a biofilm. A biofilm is a gluey type of matrix that enables the germs that are living in it to be 1,000 times more resistant to disinfectants. And this is a whole new area of science that most people won't have known about yet, but it's really been proven that this is our big target, is to kill the germs within these on dry hospital surfaces in the biofilms. So ideally also a disinfectant should have some residual surface efficacy, and of course the disinfection cannot be deactivated by cloth or mops or dirt. So for example, bleach doesn't kill biofilm and can be deactivated by dirt and cloth and so on, same as quaternary ammonia compounds can be tied up. So the next slide there, please. So behavioral change, what we're trying, just to return to the behavioral change part, behavioral change is difficult. And Medentech has the following tools to help you. We've got online training programs in best practice. We've visual checkbooks and protocols to help you. We've a technical hotline where our PhDs and microbiologists and chemists can help you. We've apps for more advanced places. And of course, we've got low-cost water, ultra low-cost water and surface infection control programs. You can go on to the next slide there now, please. So simplicity is very, very important in what we're trying to do in developing areas, low-income areas, in terms of the product itself. And this product here, ChlorClean, is designed to be ultra simple. The tablet, if you've got a bucket, this is simply the answer. So really, all is needed is one bucket. You put the tablet, 1 tablet per liter, very, very simple. It's a broad spectrum cleaning and disinfecting product 2-in-1. So it cleans and disinfects in one go. And kills all the germs that I spoke about earlier, the families of germs and the biofilms. You could go on to the next page and we just run through that very briefly. So it's really simple to use. 1 tablet in 1 liter of any water, it doesn't need to be improved source, will create a disinfectant for you. It's safe to use on surfaces and hands. Of course, if you've soap, all the better to use, but certainly this is safe to use on hands and surfaces. Very small and easy to transport. You can carry 1,000 liters of this equivalent disinfectant in the palm of your hand. It certainly reduces all packaging waste because it's so small, and it has very significant advantages over bleach, jake, quartz, and hydrogen peroxides, and so on. Next slide, please, and we're nearly complete. The other leg, of course, of what Medentech does is the water treatment, the other part of WASH. Now, we provide you with 3 different options. Here you can see on the extreme left, AquaTabs. This is a single dose method for buckets or for water containers or for trucks to disinfect the water, to kill the germs and to keep it safe. Remember that residual safety is important. In the middle, you see the Aquatabs Flow. This is a low-cost, automatic, no power required system for disinfecting water that travels into roof tanks or underground tanks. And then the extreme right-hand side, you see the Aquatabs inline system, which is for pressurized systems. They don't occur so much in some of the less developed areas, but certainly that's available as an ultra low-cost system. So you can see that what we're doing is offering both simple low-cost surface disinfection techniques and methods, and the water treatment, and together they provide a very good solution for you. The next slide there, please. Now, so just a couple of benefits then to Aquatabs. It's made in a pharmaceutical grade factory, so you can be absolutely sure of the quality of what's going into the human body, and it's broad spectrum as well. And also keeps down any biofilm growth in pipes and so on. That's with the systems. So the final slide now, and thank you for sticking with me through this rapid discussion, friends. WASH in healthcare facilities is critical, simply critical to saving lives. We will save lots and lots of lives by doing it and doing it properly. Hygiene behavior can be difficult, but it's very important. And this, as I said, the message needs to be simple, relevant to the healthcare worker, and repeated. Proper disinfection saves lives, bed days, and reduces staff illnesses, and of course those of their family as well. I've mentioned that disinfection must kill bacteria, microbacteria such as TB, fungi, spores, viruses, and biofilm. Germs have mutated. Germs are stronger now than they were 10 years ago. So what worked 10 years ago, it might not be sufficiently strong today. And finally, Medentech is here to help you. We've got training programs. We've got a product that can be used on both surfaces and hands, very, very simple. And of course, the Aquatab systems are there to ensure proper water quality for healthcare facilities. So you can go to the final slide, but I just want to say thank you all very, very much for listening to me. And I'll be delighted if you feel you can contact Medentech or any of our people to assist you via our website or via Megan. Thank you indeed.
Thank you so much, Michael, for that comprehensive look at Medentech's work in infection prevention and control. So we're towards the end of our time. We promised we'd end at 11:15, but we can't end without some questions. So if you all will bear with us and be open to staying with us for a couple minutes over time, we'd love to answer some questions. If you haven't already, please type in questions in the chat box. Otherwise, we could also open it to the room. Here we have a couple of people here in the room if they have any questions. I think we already received some questions, so I'll let Bijan give us a quick overview on some of the questions we've received.
Hi. So Ian unfortunately had to step out. He had another priority to attend. I apologize, but we had a question for him, and he provided a response. So I will read it on his behalf. The question was, did the gold, silver, and platinum level resonate well in Haiti, and are there culturally appropriate ranking systems? Ian's response is, actually, those levels were developed by our team in Haiti. Like WashFit, the Clean Clinic approach is a flexible, adaptable approach, able to be localized depending on how developed WASH in healthcare facility programming is in a specific country. Another question we have is, and I think this will be best geared for Dr. Mbola to respond, does quality assurance take into account patient views or the perspectives or thoughts and wishes of patients?
Mbola, are you free to answer that question? Did you hear it?
Yes.
Can you repeat the question, Bruno?
Dr. Lowe, do you need me to repeat the question?
Yes, please.
Okay. Does quality assurance take into account the wishes and desires of patients?
Yes. The quality assurance covers first the standards and guidelines, which are norms, and I think there are no there isn't the flexibility on norms. But on the other side, there is also the patient, the perspective. For example, when you talk about the privacy and confidentiality, it's related to the comfort of the client. We also conduct regular survey on client satisfaction. So we take into account the result of this survey to adapt or to update some of our activities. So there is the part related to standards, infection prevention and equipment, minimum standards. But there is also the patient part, perspective.
Thank you, Dr. Mbola. Now, we've talked a lot about implementation and supervision, but our next question is, how do others maintain and sustain these changes that have been implemented? And this is a question that is open-ended for any of the presenters to respond.
So Bijan, the question is how to maintain behavior change.
Not just behavior change, but changes made to programs in the field, in healthcare facilities and clinics.
Is Mbola, is that something you would be open to respond to, or would you like me to take it? Okay, go for it.
So, as we said, we provide regular supervision visit to improve the behaviors of the providers for the compliance with norms and standards. And this system is not flexible in terms of the frequency of the visit are based on their performance. So even this frequency, if we decrease the frequency of the visit, we will also follow the behavior change. Are the providers able to maintain the behavior change after that we decrease the number of visits? And so if there is some action to be done, so we will improve the activity. So for example, in the behavior change stairways, it happened that providers who is in a adoption stairway could go back to trial or other steps. So we can maintain the provider behavior change, and this is part of the support that we do, and we try to involve them more to increase their to provide continuous support, but the objective is that their behavior change will be sustainable. So after ending of ABMS support, they will continue to do the behavior.
Great, thank you so much, Mbola. Why don't we take one or two last questions, because we're already 10 minutes over. Let's go for
Yeah.
the last question here.
This is a question.
And then we'll have one in the
Oh,
room.
we'll take the question in the room.
Okay. Well, I just have a concerning.
Sorry, our question in the room is coming close to the microphone.
Questions for more vision. I was just, it's a question for Medentech. It's concerning the disinfectant product called Chloroquine, I think. Yeah. My question is two things. Is we understand that antimicrobial resistance is evolving. It's evolving every time. So trying to look at that and looking at this product, how has it been tested to ensure that it kind of looks at how it evolves with AMR. And then the second one is just looking at, have you looked at any different types of disinfectant products that are more locally made, or is this product can be locally made? So those are two questions that I have. Well, yeah, so let's just to clarify on the AMR, because I just want to know how this product does not it does not create more issues towards the AMR. Yeah, microbial resistance.
Great. Michael, do you want to take that one?
Hi, listen, I was having real difficulty hearing it. I'm afraid I just didn't hear the question properly. I only...
Okay, I'll summarize it for you very quickly, if that's okay. She had two questions. Is one, can chlorocline be produced locally? And the second one is, how does chlorocline link to AMR, meaning is the antibiotic resistance that is caused by, through time, does chlorocline help address that? How does it address that? How does it link to AMR? Did I do a good job summarizing?
Yeah, you did a good job.
Did you hear that?
Certainly. Quick question, or quick answer on the locally produced. Because we produce in such volume, we produce over 1 billion tablets a year, this enables us to give the ultra low prices, literally just cents per litre when you dilute the product. If you produce locally, it would substantially increase the price. And the second part of it, of course, is quality control. I mean, the disinfection products are in effect a prescribed item. You prescribe it to kill a particular germ or group of germs and so on. So you really need to make sure that that you have the quality correct, the dosage correct, the shelf life correct, etc., etc., etc. So there's a whole onion of quality controls around it, and that's all the more important for things like aquatabs that go into the human body. So you have to be very careful about considering local production, both from price and quality point of view. And then with regard to the antibiotic resistance, so this product is tested globally. It's US EPA approved and European approved to kill the mutant germs on surfaces. So whether it be methicillin-resistant Staphylococcus aureus or the new shades of Clostridium difficile spores, or basically I've given the whole list there of bacteria, microbacteria, fungi, spores, and viruses, and now biofilm, surface biofilm, and that it kills all of the mutants within all those categories. So that's how it addresses the non-transference. Let me give you the bad case scenario, that if you use a weak disinfectant, what you're doing is you're training germs to resist. So anything that's left behind has the opportunity to mutate, whereas this product is killing in a non-specific manner, so the germs can't mutate against it, and it is certainly tested against all those germs that I say. And we have a huge library of independent testing studies to evidence the efficacy against these mutant germs, antibiotic-resistant germs.
So we have a question directed to Arabella. The question is, what is the World Health Organization doing, or what do you see are the needs of advocacy for preventing healthcare associated infections in low income settings?
Okay, thank you very much for that question. Well, I think there's two parts to that question which I'll try to answer separately. The first one on what is WHO doing? Well, from the WASH perspective, we work very closely with the IPC team at WHO to try and align our messages and make sure that we support each other in advocacy work, so promoting materials for the Global Hand Hygiene Day, sharing technical information between the two areas to try and, as I said, align messages. And I think really the integration of WASH and IPC is really crucial to try and reduce healthcare associated infections. I think the idea that WASH needs IPC and IPC needs WASH, it's very hard to promote IPC practices unless you've got the infrastructure and the knowledge of WASH services to go with it. So we have developed some joint advocacy materials. We have an infographic on the links between WASH, IPC and AMR as a way of reducing infections, which is available on the WASH in Healthcare Facility Knowledge Portal. And we have worked hard to get WASH included into IPC guidelines. So I mentioned during my presentation the guidelines on surgical site infections and also the core components of IPC. So I think this strengthening the link between WASH and IPC is a very fundamental part to this to the ever challenging task of reducing healthcare associated infections.
Great. And we have another question. What can civil societies and non-governmental organizations do on the ground to better sustain behavior change around WASH in healthcare facilities?
Well, I think that's really a question of advocacy and awareness raising, so through behavior change campaigns and kind of sustained activities. So rather than just coming in and doing a one-off campaign, you know, having more sustained, long-lasting campaigns to try and change behavior and, you know, increase hand hygiene compliance and that sort of thing. And working, of course, with governments through policies and standards, so trying to keep messages aligned and implement national policies and guidelines where they exist. Also, of course, through implementation of WASH Fit, so we see that as a tool to try and encourage behavior change and as a way to encourage facilities to start thinking about the importance of WASH services, how they can make changes, where the most important changes are. So by doing a WASH Fit assessment to identify where there's minimal compliance to hand hygiene, where there needs to be more efforts towards hand hygiene promotion or behavior change promotion. So using the WASH Fit tool as a way to make change, we hope that many organizations, including civil society and NGOs, will take it on.
Great, thank you.
We wanted to thank all of our presenters for such great presentations. Really, I think gave people a comprehensive look at WASH in healthcare facilities and what we can do to move from raising awareness, which is so important, getting out the information about the Global Action Plan, and working with all of our organizations to take action. Some sort of key takeaways. We've already heard these things, so I'm not going to go into depth, but WASH in healthcare facilities is key to service quality. Really, we all need to work together on doable actions to change behavior, and that proper disinfection can save lives, reduce the amount of time patients stay in the health clinic, as well as reduce staff illness. Ian talked about the key point of government ownership, both at central and district levels, and that maintaining quality requires constant supervision and is necessary for sustainability. We saw that in both the Haiti case and the Benin case. In both of those cases as well, we also saw the importance of implementing a motivational system, and that leadership at the health clinic as well as the district level is really important, and social recognition can be a strong motivational tool. Of course, supply is essential, and that when we talk about this supply, we need to make sure you have the proper disinfectant tools, as Michael mentioned, because if you have the wrong one, potentially can cause more problems. Well, we're about 15 minutes over, so I wanted to thank all of the participation we had, all of the participants, your questions, your engagement. I encourage you to keep raising awareness about WASH in healthcare facilities and keep the conversation going. We have some hashtags that we highlighted in the original slide. This conversation can continue on Twitter, and I hope you will get engaged as well in the UNICEF WHO Global Action Plan working groups, and so that we can all continue to work to improve WASH in healthcare facilities. A recording of this webinar will be on the Global Handwashing Partnership's website, so please feel free to share with any colleagues who you think might be interested who are unable to attend. And don't hesitate to reach out via email. You'll see our contacts here on the screen. And I wish you all a super hand hygiene day. Thank you so much. Have a great day, wherever you may be.